I'm Dr. Christopher Bunick, Associate Professor of Dermatology at the Yale School of Medicine. I also was able to speak about JAK inhibitor safety in a whole session on JAK inhibitors. JAK inhibitors are being widely used for inflammatory skin disorders, whether it's atopic dermatitis, alopecia areata, innovation in hidradenitis suppurativa, or even in rare diseases like dermatomyositis, we're also seeing JAK inhibitors make meaningful improvements in our patients. In my lecture on JAK inhibitor safety, I really emphasized the systemic inflammatory nature of the diseases we treat in dermatology. This could be atopic dermatitis, psoriasis, alopecia areata, HS. The reality is there's a consequence to not treating moderate to severe disease. And that consequence seems to be cardiometabolic dysregulation. Part of that might be due to atherosclerosis, but what I tried to do was connect the dots between atherosclerosis, systemic inflammation, and the increased rates of cardiovascular outcomes like MACE and VTE in atopic dermatitis patients that are not on any treatment. This helps us understand how the background rates compare to patients that have atopic dermatitis that are on therapy, and particularly on a JAK inhibitor or an advanced systemic biologic, such as an IL-13 targeted agent. So what I was able to do is show that the current adverse event rates for our JAK inhibitors for MACE and VTE are actually lower than patients with moderate to severe atopic dermatitis that are on therapy. And even one step further, I showed data that an IL-13 targeted biologic, tralokinumab, has the exact same malignancy, MACE, and VTE rates as upadacitinib. All of this together is helping to shape the narrative of why we seem to see low adverse event rates for these adverse events of special interest with JAK inhibitors. This bodes well for our dermatology specialty because we have more and more JAK inhibitors coming throughout all of these inflammatory skin diseases, including upcoming alopecia areata and vitiligo and HS.